Of children and adolescents suffer some kind of mental disorder through childhood and adolescence. Fortunately enough, most of these children will not need psychiatric care or will not need to be treated with drugs, and some of these cases will be mild or transient disorders like enuresis or some forms of mild anxiety. But some others will need to be treated, some with psychotherapeutic interventions, some with pharmacological interventions. It's important to know that almost 70% of psychiatric disorders that are diagnosed in adulthood have their first symptoms during childhood or adolescence. And that's important because we know that the earlier we treat, the better the prognosis. So there is a movement in recent years to look at the prodromal phases of the different disorders, not only psychotic disorders, but also affective disorders in childhood and adolescence. That has brought a lot of attention to child psychopharmacology, which was an area that did not get many attention in the last decades. Having said that, it is true that after diagnosing a kid or a youth person with a mental disorder, most of the times we should try first psychosocial or psychotherapeutic intervention. So only in some disorders for which we have quite strong evidence that drugs are efficient, we will go straight for the psychopharmacological treatment. Otherwise, in many instances, we try to use psychotherapeutic interventions and psychosocial approaches to try to take care of the disorder. One thing we have to take into account is that children, unlike adults, are much more change much more with time. So before we make a diagnosis in children and adolescents, we have to not only interview the patient, but interview the parents and the teachers in the school, and wait a little bit of time, because it's incredible how some of these symptoms change from one interview to the other. So we may see a 8-year-old kid who looks really depressed and is crying all the time, in just 1 or 2 weeks' time, that he's fully recovered and there is no hint of that depression anymore. So before treating, we have to take into account time. Treatments are usually at the symptom level, so it's important to consider that when we treat, and this is probably not much different from adults, but it's important to consider that when we treat many of the, in theory, disorders that these kids have, what we're doing is we're treating at the symptom level. This is very easy to understand, for instance, with the treatment with antipsychotics for autism. We're not treating the core symptoms of autism, we're treating the hostility, the irritability. And that's good enough, patients improve, but many times it's not what defines the disorder that we are treating. With other diseases like ADHD or depression, that may be different, but that's definitely the case with autism and, for instance, schizophrenia, where we treat just the delusion and hallucinations, but not the rest of the diseases. So most disorders have at least some evidence base for treatment that works for them. We may think of ADHD, and there's a strong evidence that drugs like stimulants are very efficacious for these disorders. We may think of, for instance, chlormipramine in OCD, or some other SSRIs for other anxiety disorders. There's a strong evidence that these drugs work to treat these conditions. The evidence is not that strong for other disorders, and there has been a lot of attention in recent years for the issue of antidepressants and depression in children and adolescents. Probably a larger placebo effect in children and adolescents may account for that reduced effect size for these drugs in the treatment of depression in youngsters, and that has to be, of course, taken into account. So we know that there is less literature for the treatment, and there are less clinical trials in children and adolescents than with adults, but nevertheless, there is some strong evidence for some of the drugs, and we clinicians, when we treat our patients, we need to be aware of that, and we need to be aware of all the clinical guidelines that are available in order to treat these conditions. Although there is evidence base, we have to take into account the context in which this kid, in which these children or adolescents live, their educational, the education system, the relationship with their parents or legal guardians, the relationship with peers. So although we have these guidelines available, the truth is that we should treat every patient independently and taking into account everything, considering all the evidence around this kid before choosing a drug. We may have kids that have the same condition that their parents. We may treat 9-year-old kid with psychosis whose father is also treated with psychosis, and the father hates one of the drugs that he was put on. We should try to avoid that drug, a specific drug for the kids, because we know that both parents and children attach some meaning to the drugs, and that of course has to be taken into account. So I said that parents and youth attach some meaning to the drugs, and this is extremely important because there is a lot of stigma associated to psychiatric diseases, but there is even more stigma associated to psychiatric diseases in youth. And when we explain to the parents and to the children that they have to take a drug that is going to treat their mental disease or their mental problems or the symptoms they have, we have to be extremely careful in the way we do that. Otherwise, we may face lack of adherence, lack of compliance, or an unwillingness to treat that condition. We have to be able to explain that the disorder they have is not much different from any other disorder in their body, and for that we have a treatment that may be useful for them and may improve their quality of life and may improve how well they do in life. And given that information, of course, given the pros and the cons, given the the side effects information also helps, because if they experience that side effects, they think, wow, this doctor knew what was going to happen. So that's also important to provide them with all information available, and all the time we spend, or I should not say spend, all the time we are with the patient and their family, explaining what it is about with the drug treatment that we're going to provide them with. It's worthwhile and really pays off in the long term. Children and adolescents are not the same in the way they they have these internal feelings and the way they see the medication, and that has to be also taken into account. We also may we need to think that the way we provide the information has to be appropriate, so they will not understand fancy terms or some technical jargon. So we have to talk to them in a way they can understand us. When studying neuropsychopharmacology, for children and adolescents, we have to take into account also some neurodevelopmental issues. The brain is plastic, and it's plastic all over our life, but it's extremely plastic and it's extremely changeable during childhood and adolescence. So the brain changes, and the brain system changes, and the neurotransmitter systems also change. For instance, the density of dopamine receptors is much higher in 2-3-year-old kids than in adolescents. So these small children are extremely prone to have side effects, EPS side effects. The same will happen with the serotonin and neurotransmitter or serotonin or norepinephrine system. The serotonin system is established very early in life. Meanwhile, the norepinephrine system develops with time. So for small children, we should try to use drugs that work at the serotonin level and not at the norepinephrine level. We have also to take into account pharmacodynamic and pharmacokinetic issues. For instance, we don't have to think that children are just small adults, and if we treat an adult whose weight is 80 kilos, or we treat a children whose weight is 20, we just need to divide the drug by 3, because that's not going to work. The metabolism in the liver for children and adolescents is usually increased. So usually we have to use larger dose than expected for the weight or for the BMI. That alteration in the distribution also needs some time that we adjust the drug, and we don't give the drug only once a day, but 2 times or 3 times a day. So those are pharmacokinetic and pharmacodynamic issues that have to be taken into account when we prescribe drugs to children and adolescents. I said before that there is a strong evidence for some drugs for some conditions, but the truth is that it has not been until recently that clinical trials and randomized clinical trials have been put in place. So we're still lacking a lot of information, especially regarding efficacy and safety issues. The truth is that nowadays psychotropic drugs are widely used in this population, but we have learned in recent years that side effects that the kids, the children and adolescents experience are even more than those experienced by adults. In some studies that we have conducted, we have shown that with some of these drugs, for instance, for the treatment of early onset psychosis, for children that are drug naive, so they have not been exposed previously to antipsychotics, they have larger than expected side effects in terms of the metabolic profile. So they increase the cholesterol, and they have more insulin resistance, and they increase their weight to a larger extent that we have seen with adults. This altogether may tell us that we have to be extremely cautious, and when prescribing a drug to children, we have to take side effects into account, and we have to from time to time see if that drug is still needed, or we can stop. So the key messages would be that we need to know more about efficacy and safety and tolerability issues in children and adolescents. B, the drugs that have shown to be extremely efficacious for the treatment of some of these disorders, although we need more information. And C, we need to take into account everything related to neurodevelopment, both from the pharmacodynamic and for the pharmacokinetic point of view.